Okay, I've got 12 o'clock, so we'll go ahead and get started. This is Ann Garvey. I'm with the Iowa Department of Public Health, and as always, we greatly appreciate you taking the time to spend with us for this webinar today. We've got quite a bit of information that we want to go over. A lot of it is EPI related or investigation related. So it'll be most relevant for the local health department partners and infection preventionists that are on the line today. As always, this webinar will be archived, so you can view it at a later time, and we will send out the slides. So I want to start off our discussion today with some updates that CDC has made to guidance. And so they have recommended that we increase the number of days that have passed since someone either begun having symptoms or if they were asymptomatic until 10 days after the date that they were first tested. So previously the recommendations were 7 days and 10 days for healthcare providers. Now CDC has recommended 10 days for everyone. And so that's a change that we're going through our guidance documents and having to make, and I'm sure you guys are as well. We're also updating this information in IDES. It should be updated now, but for any new case that is reported, the final tab in IDES talks about the 7-day recovery, the 7-day check-in. That should now be moved to 10 days. CDC also updated several of their additional guidance documents related to what to do if you're sick, so I've included those links on this slide as well. Like I mentioned, CDC had also recently updated to 10 days for healthcare providers only. So there was a few days when they just went to 10 days for healthcare providers. But now I just want everyone to know that it's 10 days for everyone. So again, if you test positive or you have symptoms, 10 days. So if you're symptomatic, you should be symptom-free for at least fever-free for at least 72 hours. Your other respiratory symptoms should have improved, and it should have been at least 10 days since your first symptoms started. If you're asymptomatic and test positive, then you should be excluded until 10 days after the first time that you were positive. So let us know if you have questions. CDC also updated their return to work criteria for healthcare providers. So again, the link is included on the slide. Last week, we got some questions from all of you related to screening guidance. And I'm sure that most of you have seen that CDC has kind of updated the symptoms that they feel are related to COVID-19. So they're saying people who have a cough or shortness of breath, or at least 2 of the symptoms listed on the slide. So at least 2 of the fever, chills, repeated shaking with chills, muscle pain, headache, sore throat, or new loss of taste or smell. And so what some of you asked on last week's webinar was whether we would recommend updating or changing the business screening guidance. And because it would be so complex to try and institute this algorithm based on these new symptoms that CDC has identified, we are not planning to change our business guidance. If businesses want to create their own algorithm based on the updated symptom information from CDC, they're certainly welcome to do that, or they can continue to use the screening algorithm that we have posted on our webpage. And I've included that link there, and that's based on fever and respiratory symptoms. So I'm going to switch gears, and I want to talk for a second about the CDC guidance for critical infrastructure workers exposed to COVID-19. So their definition of critical infrastructure workers is listed on the slide here. It's a pretty broad category of individuals. And basically what the guidance says is, if someone is exposed to COVID-19 and they're a critical infrastructure worker, they can continue to work as long as they remain asymptomatic. And there's some additional guidance that CDC recommends in these situations. So before the employee that's been exposed comes into the facility, they should have their temperature checked and assessed for symptoms. Regular monitoring to make sure that they don't have any symptoms. They should be wearing a mask at all times while they're in the workplace. Should be social distancing, and cleaning and disinfection should be occurring in the facility. So we've had some confusion about 7 days, 10 days, 14 days. So I just want to go through that really quickly here. So if you're exposed, then the amount of time that we want you to be isolated for, or to take these measures if you're a critical infrastructure worker, is 14 days. And that's based on the incubation period for this virus. When we're talking about how long you should stay off work or you should self-isolate because you either have symptoms or you test positive, that's based on the infectious period. And CDC has now increased that effectively to 10 days, where it was previously 7 days. We will be pushing out some new testing criteria. Again, this criteria is only applicable to the state public health lab. As you all know, there's testing resources pretty widely available through many reference laboratories. So the big change here is in the bottom bullet, where we would test any healthcare workers or essential service personnel, first responders, or critical infrastructure workers with any fever or respiratory symptoms. And so that would really broaden the ability to test people who may have either fever or respiratory illness who fit into that category. So we'll be pushing this out today and updating everything on our website. We've had some questions about whether SHL will be able to do testing for kind of clearance for elective surgeries. And at this time, due to supply issues for the testing materials that's needed to do the NP testing, SHL will not be able to do that testing. So that's an important piece of information, especially for our hospital partners. So the elective surgery pre-testing, that cannot be done at the state hygienic lab at this time because of supply issues. So that will need to be done either in-house if you're running tests in-house, or through a reference laboratory. In the coming days, SHL is going to continue to look at their supplies and look at their capability to increase testing, and that will likely change down the road. But as of right now, they aren't able to bring on that added number of tests. So I want to talk a little bit about how lab results are reported in the Iowa Disease Surveillance System. And there are really two main categories of testing. There's the PCR testing and there's serology testing. And so previously we had both PCR and serology testing information kind of going in under the same umbrella or same disease type, the 2019 novel coronavirus. And that has caused some confusion and issues for some AIDS users who were trying to pull their own data. They weren't able to effectively separate out those serology results. So in order to just streamline it, what we've done is created a separate disease type or separate event type in AIDS. So all of the PCR results will go under one disease umbrella, and that's written there in red, 2019 novel coronavirus. We didn't change that because that's been the label we've been using all along, and we want to be as consistent as possible. And now serology results will be under a different disease type called serology COVID-19. And so all of the previously transmitted serology results, our information management folks are pulling out of the 2019 novel coronavirus, and they're putting them into the serology disease type. So you should be seeing that happen if you haven't noticed that already. So I want to talk about what the PCR test tells us and what the serology test tells us. And the PCR test really is an indication of likely current COVID-19 infection. And so this is going to tell us who potentially is infected and who is potentially infectious. And so that's why, based on the positive PCR test, we're recommending that people are self-isolating again now for the 10 days. What the serology test indicates is either a past or a recent COVID-19 infection. And we've gotten some questions from our local public health partners related to whether there is cross-reaction between the 2019 novel coronavirus or COVID-19 and other more commonly circulating coronaviruses on that serology test. So I talked to Dr. Pintella at SHL about that this morning, and he has not seen a problem with that. Now, I know that it prints that out as kind of a disclaimer on the lab result. That's a requirement of the kit, but they haven't seen, there seems to be a good correlation, and they haven't heard of any cross-reaction concerns nationally. So again, if you see that on the lab result, that is a requirement that needs to be printed out as part of the testing kit. But again, there's no indication that this is a significant issue or that we're seeing a lot of cross-reaction. So again, those serology results indicate either a past or recent COVID-19 infection. Because these are people who are recovered and should no longer be infectious, we would not recommend that people who are serology positive self-isolate because of that result. They should still be doing what we're recommending for everybody in their area at this time. But as far as needing to abide by what we previously called the 7-3 rule, now we're calling it the 10-3 rule, that is not something that needs to be done for these serology positives, because these people, as long as if we have a PCR result and it's negative, then we shouldn't be considering them infectious. So there have been a couple of times where someone has tested both PCR positive and serology positive. That's not something we've seen commonly. We've just seen a couple of those. And in those situations, we would default to the PCR results. So if someone's positive for both, potentially we just caught them on that little bit of overlap period. So we would recommend that that individual self-isolate for the 10-3 rule. So really we're defaulting to the PCR test to tell us whether the person needs to self-isolate. So if you have any questions about that, you can certainly reach out to us. We're happy to walk through it with you. I've included some links on this slide for some additional information about the PCR and serology tests. So as I'm sure you've all noticed, we are getting a lot of lab results from a lot of different labs, and many of these are coming in without addresses or phone numbers. And we've had many people assigned to be looking up these addresses and phone numbers, even for the negatives, because we want to report out negative tests by county. We know that a lot of you are using that information, and they're using that information at the state level as well. So that's been a pretty heavy lift for us, just looking up addresses. We've given feedback back to labs to please include those addresses and phone numbers, but if the provider doesn't include that information on the test request form, then there's nothing that the labs can pass through. And so to all of our healthcare partners, we'd ask you to please make sure and include that information, because the results can't get through the surveillance system without an address. So what we've started implementing over the weekend is we're working with basically an address lookup system company called Clear, and right now we're manually extracting any cases that don't have addresses, and then our IM is inputting those addresses back into IDES. We're working towards automating this process. This is going to take a little bit of time, but what we'd like to see is in the future, if cases come into IDES without an address, they're automatically funneled through the Clear lookup system, and the address is added right away. But in the meantime, we're doing this kind of more labor-intensive export-import process. Again, we tried this for the first time over the weekend. It worked relatively well, but one of the unintended consequences is when cases are already reported to the system and then we go back and add an address, it doesn't trigger a new alert for that case. Meaning, if they came in without an address and then we find out, for example, the person lives in Hamilton County and we enter that information, the system won't send a new alert to the county. And so we're working with IM to try and resolve that issue. We apologize because we know that for some of you, you didn't receive alerts on these new cases that came in that we found addresses for. And so there was some surprises on that map. We really apologize for this. IM is, again, trying to write some code that would then fix this problem moving forward, but we appreciate your patience. I think this is a good time to just kind of take a step back and say, we know that things are changing on an hourly basis and daily basis. That's happening on the national level, the state level, and the local level, and we appreciate your flexibility and patience with us. And our staff, I know our field EPIs have talked to a lot of our local public health partners in the last few days, and we understand that there's frustration and we apologize for that. We're trying to move as quickly as we can to make things as most straightforward for all of you and for us. And just again, I want to reiterate that we appreciate your patience. So I want to talk a little more detailed about the PCR case investigation and contact tracing procedures. And I apologize, we had hoped to get the changes made to the IDES cases by Monday. That didn't happen. The changes are now made in the system, so we'd ask that you start doing this as soon as you can implement these changes if you haven't already. So we're asking that for the local public health partners that are doing their investigations, that they continue to do the investigation with their normal procedures. And then they also identify all people that the case had contact with during their infectious period. So again, we talked about infectious period previously, but I'll cover it again. We would consider an asymptomatic person to be infectious from 48 hours before their test was taken through 10 days after the day their test was taken. For someone who was symptomatic, we would consider them to be infectious from 48 hours before their illness started until they've been fever-free for at least 72 hours. All other symptoms have improved, and it's been at least 10 days since their symptoms first began. So again, we'd ask you to, as you get cases reported, identify what the infectious period is and ask those individuals who they would have been in contact with during their infectious period. And by contact, we would consider those to be people that have been less than 6 feet away from them for more than 30 minutes. So we'd ask that you identify all the people that would meet that contact definition, both people they live with and people that they don't live with. Contact these contacts, ask whether they've been ill, and instruct them that they've been exposed to COVID-19, and then provide the isolation guidance accordingly. So all contacts should be recorded in the contact section of the Iowa Disease Surveillance System, and I'll show you what those screenshots look like here in a second. And anyone who's an ill contact should be then entered as a new case or an epi-linked case within the Iowa Disease Surveillance System. So here's some screenshots of the contact section. So the top section has always been there. It's the household contact section. We, again, recommend that you continue to use that as you have in the past. It's the bottom section that's new. So all other contacts who meet those definitions that I just went over within 6 feet for more than 30 minutes with the case during the case's infectious period should be recorded down here. And I should have taken another screenshot, but when you slide over, there's a box that says, is this person symptomatic? So obviously, if the person is symptomatic, you would check the box and then enter them as a new case. So I think our local public health partners are pretty familiar with this process. So last week we got some questions about contact tracing within healthcare settings, and CDC has recently changed their guidance on this issue. And so they're saying that because everybody should be using full PPE in the healthcare setting, that there's not a need to do contact tracing for exposures, because again, that universal use of PPE or source control for healthcare providers and that screening should be occurring with every shift. And so I just want to make sure we talk through that with our healthcare partners on the webinar here today. So if there was a situation where a healthcare provider wasn't wearing appropriate PPE, then it would be important to do more contact tracing. But if everybody's universally using the PPE, this is CDC's recommendation. Okay, I want to transition to the serology results. So as we talked about, those serology results are going in under a new event in IDES. And so we are going to ask that local public health partners, or we can help with that, and we'll talk about the helping part in a minute, start conducting investigations for persons with positive serology results. So again, there's a form in the system, and we'd recommend that you take the same procedures that you have been taking. We don't recommend going backwards for previous cases at this time. We just recommend with the new cases that are reported. The serology positive results, again, would indicate a past infection or a recent infection. And so without a positive PCR, for most people, we would assume that this person is no longer infectious. The infectious period can't be determined, so we're not doing contact tracing for serology results. It's just the standard follow-up. And when you see those follow-up forms in IDES, you'll notice that we're asking questions going back 6 months. So have you been sick in the last 6 months? What were your symptoms? Did you travel? Were you around anybody else that was sick? So those are the key questions that we're asking in that serology form, that serology follow-up. It is shorter than the PCR follow-up. So again, we're asking that follow-up starts on Monday, and that information is in IDES. The disease itself is in IDES. So I want to transition again and talk about long-term care, illnesses, and outbreak investigations. So our local public health partners that have had illnesses and residents in their long-term care facilities know this process already. I've also talked through it on previous conference calls / webinars. So I want to just quickly go through it again. So when one or more residents of a long-term care facility test positive for COVID-19, then the local health department and our staff hold a call with that facility, and they go through all of the recommendations listed on the slide. So are they screening all employees for symptoms at the beginning and end of each shift? Are sick people being sent home? Are the sick residents in single rooms? Are they cohorting staff so that dedicated staff can work with the ill residents and other staff are working with healthy residents? Are they using appropriate PPE? Have they closed to visitors? And all facilities should have been closed to visitors by now. Are they screening patients regularly for symptoms? We also recommend that they coordinate with the local health department and EMS and hospitals to just plan for how they were going to transfer patients if their residents get more severely ill and there's a need for a higher level of care. We also make sure that they understand that the resident's illness is likely to worsen 7 to 8 days out from when their symptoms started. That's what we've been seeing in these situations where people will drastically decline after that time period. We also advise that they work with local public health to ensure that there's adequate supplies, both PPE and testing. We also have them talk about the communication plan that they're going to use with their staff and residents and families, talk about hand hygiene, PPE donning and doffing, their cleaning procedures and the products they're using, and then again, some of the PPE and staff contingency planning. So from that day forward, we ask that local public health contact the long-term care facility daily just to check in, to identify newly symptomatic or confirmed residents and staff, to talk about those cases and whether there's clear epi-links to previous cases. Are they roommates, for example? Or all of the illnesses in the same hallway of the facility or neighborhood of the facility? How are they adhering to PPE use? Are they having any trouble getting environmental cleaning products, and are there procedures in place? How are they cohorting staff? Is their PPE supply holding? Do they need more testing? Are they having issues with current staffing? So again, these are questions and information that the local health department goes through with the facility on a daily basis, and this is after the facility identifies illness in at least one of the residents. So we want to modify the way that we're tracking these cases as in both staff and residents. And so in the past, we've used a spreadsheet, and we've asked that our local health partners work with the local health, or excuse me, the long-term care facilities to update this spreadsheet or line list. But we'd like to transition to recording these new cases in IDES. And so we're in the process of updating all of the old cases, and would like our local health partners to start doing this going forward on Monday. Right now, this field is not available to local users, and IM is working to make this field available, and so that's why we're saying please start on Monday. You probably won't be able to do that today, likely the end of the day tomorrow, but we'll just start on Monday to make sure we've got adequate time to get this updated in IDES. So basically what we're doing is our staff will create an outbreak name for each facility that's based on the county where the facility is located and the name of the facility. And then we would ask our local public health partners to go through and link any cases or negative testing results, so both positives and negatives in both staff and residents within the IDES system. So the outbreak/exposure tab is located on the event continued tab in IDES. And so what you would just need to do is you would click, is this outbreak related? Yes. And then under the outbreak, that's obviously kind of a multiple choice, and you would just pick the one that is related to the facility where this person either works or resides. So again, we're asking that our local public health partners identify the long-term care facility for each one of these patients, so both the positive and the negative patients within the IDES system. We are, again, in the process of going back, looking at the spreadsheets that we do have and making those assignments to the outbreak designation in the system, and we will have that done by the weekend. But going forward, again, starting on Monday, we'd ask our local public health partners to start doing that. Again, we think this will be potentially less work for local public health and for the facility than keeping that line list. However, if those local public health departments that are using that line list like using that process and it's helpful for them, they can absolutely continue to use that line list. That's your choice. We're not opposed to that in any way. We're just saying you don't need to send that to us. We're trying to streamline the process a little bit more. So I just want to clarify that we are asking that local public health partners start making this designation across the state, regardless of whether they're doing their own case investigations or not. So we've heard from a lot of our local public health partners that they would like to work more with their long-term care, and they would like to be more engaged in this. And in the next slide, I'll talk a little more broadly about another ask that we're making. We've, again, heard from several of you that you would like to continue to investigate long-term care resident cases. Since you're already coordinating with the long-term care facilities on a daily basis, this might be a more streamlined process. So we're going to try and go that route. So even local public health that are not doing other investigations in your jurisdictions, you will have the option to do investigations of long-term care residents. We think it makes sense to deal with the long-term care staff members, similar to what we're doing with all of the other case investigations, because a lot of those people may live in neighboring counties. So I think just to make that more streamlined, we would only include the long-term care residents. Now, for those local public health departments that are not currently doing their investigations, it's going to be important, but they do want to do these long-term care resident investigations. It's going to be important to update that outbreak field as quickly as you can, so we don't accidentally assign a resident case to the National Guard team that's doing contact tracing. If we do, it's not that big of a deal. If the Guard calls the long-term care facility, calls the case and reaches a long-term care facility, they'll just discontinue the interview and tell them that their local public health department will be following up. And again, because we think that many long-term care staff members may live outside of the county where the long-term care facility is located, we think it makes sense to continue to address those investigations like we are all other investigations in that county. So hopefully this is straightforward. Again, basically what we're doing is giving local public health the option to do the case investigations for the long-term care residents if they choose to do that. Now, if local public health doesn't want to do that or doesn't have the capacity to do that, we can definitely continue to do it, but we've just gotten some requests from local public health that we reconsider that. And because of the reasons I mentioned previously, we think that might be more streamlined if the local public health department has the capacity. So I touched on this already. So starting Monday, we're not going to request that local public health and long-term care facilities update those line lists, but if you want to use those local public health with your partners, you can absolutely continue to do that at your discretion. We just don't need those line lists. Again, we would really like everyone to start assigning the outbreak based on the facility where this person either works or resides in IDES, again, for both positive and negative results. We've had some questions about long-term care facility outbreaks and how those are reported. And so I just want to take a second here to clarify that. So long-term care facilities that have at least 3 residents that test positive for COVID-19 are listed on the dashboard on the COVID Iowa webpage. And so going forward, that data will be exported directly from IDES based on the facility that is tagged to the individual within IDES. And facilities remain on that dashboard until 28 days after their most recent case was identified or that case became ill. So the 28 days is based on the 2 incubation periods, which is our standard for investigations for when we would consider the outbreak to be over. I'm sure some of you may ask so I'll just address that up front. We are asking you to tag an individual resident who is ill in a healthcare facility to the facility under that outbreak code or that outbreak field that I just showed, but we will not post that on the website or consider that to be an outbreak until there are 3 residents. So we know that's a little bit confusing, but I think that's the cleanest way to track that information. and then we'll just know if there's only one case associated with it or 2 cases that they don't meet the outbreak definition. So I want to take a second and talk about the assistance that we can provide. So there are state resources available to assist with both the PCR and the serology investigations, and we defer to our local public health partners as to what kind of assistance that they would like. We will be sending out a new survey later today, asking our local public health partners, do you want to do all of your PCR investigations? Do you want to do all of your serology investigations? Or do you want to do your long-term care resident investigations? So local public health partners, you can pick any series that you want in there. If you want to do all of them, that's great. If you don't want to do any of them, that's fine as well. You just pick what you can do based on your capacity. We've had some questions about investigating cases that are identified through strike teams and through Test Iowa. And I just want to clarify that cases that are being tested through the strike teams, and that testing might be completed by LabCorp. Some of it might be completed by SHL. There's kind of a mix of where that testing is going. Those cases, as well as all of the Test Iowa cases, are being reported through IDES, just like any case that's identified through a health system. There's no special questionnaire that we're using for these cases. We're just investigating the cases as we normally would. We had a question from someone saying, how do I know which of the results came through the Test Iowa system? If you're curious, again, there's nothing we would tell you to do differently with those cases versus a case that was identified through any other route. But if you're curious, the only way that I think we can identify those is they would be ordered through Dr. Padati. So you would see her as the requesting provider. And if you wanted to go into the lab tab of IDES, it will still say state hygienic lab because that's where the testing is being performed. But the accession number for the cases that are coming through Test Iowa is very different from the accession number that is normally coming through all the other samples being tested at SHL. For the Test Iowa samples, it's a combination of letters and numbers. And for all other tests, it's just numbers. So if you're curious, that's really the only way to kind of identify it. The Test Iowa, again, would be ordered under Dr. Padati, and under the lab tab, the accession number is a combination of both letters and numbers. But again, we're not asking local public health to do anything different with these cases than they would any other case that's reported to them. So we are going to discontinue asking for the 10% absenteeism reporting through businesses. And the real reason that we're going to pull back on this is because, as I went through earlier in the webinar, the state hygienic laboratory testing framework is broadening now, and it's going to allow critical infrastructure workers presenting to healthcare with symptoms to be tested at SHL. And that was one of the big things that this reporting triggered. It triggered a more broad testing for all employees who had symptoms. And so we'll be updating our website. And I apologize, I didn't get this slide all the way updated. So the information that will be on the website will just say that businesses seeking support or consultation, they'll be directed to call their local health department, or we'll put some additional state leads on that website as well. So that change will be updated later today or tomorrow. So I know that was a lot of information. I'm sure you have questions. I'm looking at the Q&A and I'm seeing a lot of questions already. So we'll just make that transition over to the question and answer box right now. Rebecca Curtis has come in with me too. So if you have questions more related to strike teams or anything kind of non-epi, Rebecca can help us out. A good question. As areas of the state begin to open up, will there be relaxing of the 14-day quarantine for anyone that's traveling out of Iowa? So that's something that we've been looking at Earlier today, the CDC has seemed to change their recommendations on travel, and so we'll be looking at that this afternoon and be updating those that guidance as well. I should say that all of the information that I went through on our webinar today is included in a guidance document that I'll be sending out at hopefully at the end of the day, and so you can reference all that information there. But I will also address this 14-day travel quarantine for anyone that travels out of the state in that guidance document, so you have it all in one place. We know that it's hard to keep up with all of the guidance documents that are posted in all different places on CDC and on our website and things we go over on the webinars. And so this document is an attempt to kind of bring it all together for you and give you the most recent updates, so you're not having to search for them. A good comment. Our local hospital had a mental health committal this weekend where they were looking for a placement for the client but could find no mental health facility willing to take the patient because the patient had tested positive for COVID 5 days earlier. The only option at that point was for the hospital to hold the patient for the remainder of the isolation time. And so this person is just asking for guidance or information on how to handle these situations. I think that's a great question. That's something I'll take back to the people here at the SEOC and see if we can get some additional guidance pushed out through our mental health partners. But thank you for that comment. So we have a question about the DOMO dashboard, and thank you for that question. I should have included that in my comments earlier, but we anticipate moving to the DOMO dashboard probably yet this week, potentially tomorrow or Friday. And so really that dashboard is going to look pretty similar to what we have for Tableau. So there shouldn't be anything that drastically different. There will still be the ability to identify the numbers of positives and negatives by county, and also the deaths by county will be posted there. So it's the same types of information. One added feature I think that is different from what we currently have on the website is if you pick a county, you can see numbers of cases and then the age breakdown and race and ethnicity amongst those cases in the county. So I think that's a new level of data that wasn't previously available. We have some questions about the risk score, and we've gone through that in previous webinars, so I didn't include any of that today, but certainly we have some documents that we've previously distributed that kind of explain that risk score. So I'm making myself a note to send those out with the larger guidance document that I just mentioned after the webinar later today. We have long-term care facilities and group homes that test positive for COVID. We have followed the 10.3 guidance and they have been released. However, they will call back a few days after that, stating that symptoms have either returned or worsened. How would we handle this? Is there a consistent message so that all employers and employees receive the same guidance? That's really interesting. I appreciate that feedback from the county. Let me talk that through with Dr. Padati. That's not something that we had heard was happening widely previously. So let us have some discussions about that and potentially call CDC, and we'll have some additional information coming. Is it true that the state is no longer calling people who have been tested, both diagnostic and the blood test, unless they are positive? So I think I'm following that question. So there are some situations where the state has been giving results, And those are situations where there was like a group testing event and there was no occupational health provider for that facility. So for example, assisted living facilities who may not have an occupational health provider or medical director. So there have been some situations where the state has called with results, but we are really trying to transition these strike teams to a point where we are having all of those tests requested under the medical director or occupational health provider, and then those results go back to them as the ordering healthcare provider, and they would make those notifications, and then public health would follow up with positive cases. So again, there have been some situations where the state was calling results in those special testing situations, but as a general rule, the person who's being tested should be getting the results back from the provider that's testing them. Can the guidance that I've referenced be put on the IDPH website? And we can put that guidance document that I've talked about on the website. We'll also send it out via HAN. Questions about what are the recommendations for Little League and softball after May 15th? I know that there's a lot of questions that you all are getting related to this. I'll say I'm getting them as well for my kids. Everybody kind of wants to know, when can ball start again? I don't have any updates to what that is going to look like, or that timeline, but certainly those will be recommendations that the governor makes in the days ahead. So again, I don't have any kind of forecasting or timeline for you. I fully acknowledge that that is something that we're all getting a lot of questions on. Is someone supposed to notify a funeral home of the COVID test? If so, who? That's an interesting question. And so let me talk that through with Dr. Klein. I mean, I know there's a normal process for notification of infectious disease, suspected infectious diseases from the healthcare facility where the person passed and to the funeral home. In this situation, we're telling our funeral homes to use standard precautions, so I'm not sure there's anything new or different that they would need to do, but I can clarify just how that notification process normally happens, and that's how it should continue to happen for COVID-19. I'm just not familiar with that aspect, and so I'll get some additional information for next week's call. Thanks for that question. Is it the day tested or when the results come back if the person's asymptomatic? Good question. So it would be we would start counting the 10 days in an asymptomatic person from the day that the test was taken, so the day the specimen was collected. So as long as they stay symptom-free for those 10 days after they were swabbed, then they can be kind of released to, I'll say, normal activities for what we're at right now. Any recommendations for garage sales or yard sales? Again, that guidance would all come from the governor's office and proclamations and some of the information that she would be discussing. I don't have any timelines for those as well. Have they stopped asking about travel anywhere? I'm not sure the context of that, if that's during the case investigations or if that's during like screening. The screening guidance has transitioned to really symptom screening since we have this virus circulating across the state. So I think that's been resolved. Okay. Good question here. What should a person do if they get an inconclusive test result? In those situations, it's recommended that that person be retested. And if they don't want to be retested, I had this question come up yesterday. They didn't want to get another nasopharyngeal swab taken, which I understand. So in that situation, they should just self-isolate as if they were positive, and stay home for the remainder of the 10 days from the day they were tested or until they meet the 10-3 rule. I have a comment that someone's having trouble with the sound. Again, this will be archived. So if you weren't able to hear it, you'll get the archived link. Some questions about our firefighters, healthcare workers, or critical infrastructure employees. All of the guidance is really aligned now, so it doesn't really, you can technically, I guess, put somebody in whichever bucket you wanted, but the guidance should be aligned. A good question here. The CDC website states that there's a 2-test method for COVID healthcare providers returning to work. So because we're trying to conserve, testing resources, we have not been pushing that 2-test method. If a healthcare facility chooses to use that method, certainly that's their decision. But we're recommending going with the basically the return to work guidance that I went through earlier in the presentation. Any guidance for county fair boards? I'm sorry, same issue as the garage sales and T-ball and stuff. Do public health employees responding to COVID count as a healthcare worker? So again, the guidance for critical workers and healthcare workers is really the same. And so if someone is exposed and they work at public health, then they can continue to work. They just need to wear a mask and follow all of those other guidance that I talked through earlier in the slide. If an epi-linked case tests positive, will local public health get an AIDS alert? That is a good question. And that's something I think the answer is yes, but I want to run that past IM because the event would already be in the system and you would have already done the follow-up, so you wouldn't need to do the follow-up again. But you would want to do additional contact tracing. So yeah, good question. We'll follow up with you on that. A question about, I want to get serology tests from my clinic. How do I do that? At this time, SHL is doing some serology testing. We anticipate that serology capability is going to go up in the coming days. And so we haven't widely opened up serology, but if you have a request for a facility that wants to do enhanced testing, make that request through your EMA, your Emergency Management Coordinator, through WebEOC. Will PCR and serology tests show as 2 different cases if it's on the same person? So the local public health departments are probably more familiar with the system, but it's a case-centric system. And so it's based on the AIDS number is specific for the person, and the person can have multiple events. So for example, if I had salmonella last year and I was COVID PCR positive today, I might have multiple events that are linked to me as an individual. And so the way these will show up is multiple events. So if I had salmonella last year and I tested PCR positive this year and serology negative this year, when you look me up in the system, you're going to see one salmonella positive, you're going to see the 2019 novel coronavirus event positive, and you're going to see the serology result negative. So it's linked to the same person, but they're 3 different events. So if you have questions about that, just follow up with your field epi. Can we report both positive and negative serology test results in IDES? Yes, please do. I assume that's from a lab. Yes, we'd like both positive and negative serology and PCR results. There's a question, so if the test has numbers, is it positive? I'm not following up on, or I'm not following that question, so if you could follow up with us after the webinar, that'd be great, or add clarification. If someone has serology that is positive, no quarantine is required. That's correct. The only thing that would change that answer is if the person also had a PCR that's positive. Is the essential worker document still available? So because CDC came out with what they're calling critical infrastructure worker, we've just transitioned to using their guidance document. So that's the link you'll find on our website under the essential worker tab. I think some of these came in when we were starting the presentation. So do we have to do follow-up on positive serology? So I think we talked about that. If you have lingering questions, touch base with your field epi. Is there an estimated time for pulling previous serology results? Yeah, they were working on it last night into today. I'm thinking that most of that's already been transitioned. So what the question was is pulling the serology results from the PCR event, the novel coronavirus event, into the serology event. So that's likely completed now. They might be still doing some additional cleanups, but the bulk of that's been transitioned. A lot of questions about, do we do serology follow-up? We have a packing plant that has about 10 positive cases right now, and many are awaiting results. One person lives in our county, but we have not gotten anything on that yet. So as soon as we get results reported to us, they will be going into IDES. So when they're available to us, they're available to our local partners. We have, again, I mentioned this, we've transitioned to be using LabCorp. And we have one situation where the facility has gotten a few results, but we haven't gotten it yet, and we're following up on that. I'm guessing this might be related to that situation, and we're working on that right now. Do you mean the address of the clinic that did the test or the patient's address? I'm thinking that's linked to another question. I'm not following, so if you want to resubmit a question, that'd be great. What is the time frame on weekends that cases need to be contacted? Okay, that's a good question, and I'll include that in the guidance document. We'll probably keep that similar to what it has been in the past. But for the sake of having that all in one place, I'll include that in the document as well. So thanks for that question. Okay, in our IDES, we have a person listed twice with 2 different addresses. Yeah, can you call either your field epi or Jill Newland on that? Sometimes what happens is there's a hyphen in one result and there's not a hyphen in the other, and the system can't match people up correctly. And again, we're getting hundreds of results a day without any address at all. And partial phone numbers or no phone numbers. Again, the quality of the data that we're getting right now is just honestly frustrating. And so we're trying to make sure that we're getting as much information entered into IDES as we can find. But please understand we're kind of doing our best, and there's some real problems with the data that's coming in. And we're trying to work backwards with the labs to make sure they can pass that through. But again, part of the problem too is if a provider doesn't collect it, there's nothing that can be passed through. So it's a multi-level issue. Our local public health partners know that we've had that issue for years. It's just being really exacerbated in this response because of the pure number of results that we're getting. So thanks for your patience with that. Oh, okay. I have another question. I think that might have been the same person. Is it the address and phone number of the lab you need, or the patient address and phone number? It's the patient address and phone number, because again, we assign those cases out to the county of residence. So we need that address of where that person lives, so we know where that case should be sent as far as which county. So while we want the lab address and phone number too, it's the patient address and phone number that's a showstopper for us. Another question about what about EpiLinks that were originally negative and then test positive? Is there an alert issued? I appreciate those questions, and I'll follow up with IM, and I'll have that information for next week's, or I'll send it out in this guidance document. Just a comment that we've seen some people twice, once without a hyphen and once with a hyphen. If you see those, just reach out to Jill, and she can help get those fixed in the system. Just an FYI, some of our counties have Amish that may not have a phone number to list, and several families might have a shared message phone. No, totally understand that. Thanks for that comment. We're hopeful that we can at least get an address in some of those situations, so then we can make sure that the system is assigning it out appropriately to the right local public health department, because obviously if there's no address, nobody, you're not getting it and can't work through your normal channels. So good comment. We appreciate that. How is contact tracing being done for people who are asymptomatic? That's a good question. So I touched on that earlier. Maybe, yeah, this came in before we got to that. But basically, 48 hours before the person was tested until 10 days after the person was tested would be considered their infectious period, and we would be looking for people who would have had contact with the individual during that time period. A lot of these are still, as always, I'm not going to get to all of these questions, but I'm going to do my best and keep going for another 10 minutes. But I'm going to go to the end, because a lot of the ones I'm getting now, I think, came in before we talked about things. Where is the contact tracing form? So the contacts should be entered into the contacts tab. I'm going to go backwards in the presentation. So if they're household contacts, they go in that table. Now, when I say that table, I mean the case themselves. So anybody they live with gets entered in the top screenshot here, and anybody else who meets the contact criteria would get entered into the bottom table. And so that's where those go. And if someone is symptomatic, again, when you fill out this tab at the bottom and all the way to the right, there's more fields there that are just not shown. There's one that says symptomatic, and it's a checkbox. If the person's symptomatic, you check that box and then enter them as a new case. So if you have questions about that, just contact your field epi. A question about businesses that have multiple positives. At what point do they deploy testing, and who makes that decision? So if businesses are interested in testing, then that should be sent into WebEOC by the emergency management coordinator. So if there's questions about whether the business can be tested, again, it's important that you're locally having some discussions with that business before you put them in WebEOC to make sure that the business is willing to test. But that's the process it should take. If someone moved here from another state and says they have the virus, should we pursue this and contact the public health in the state they came from, or put them in isolation, or make them get tested here? That's kind of a special situation. That's an interesting question. I think in those situations, let's deal with that on a case-by-case basis and try and address those with you. Just call your field epi. Is there a serology case form? Yeah, so the serology follow-up is in IDES. The event is in IDES, and we'll get a form created and posted as well. So thank you for that. Rebecca, I'm looking for some for you, and I don't see any.
I've answered all their questions already.
Okay, sounds good. We were told that a local pharmacy is going to start being a point of service screening for COVID-19 at a drive-through window starting at the end of the month. Are we aware of this, and how is this being reported? I don't think this is not on Rebecca or I's radar right now. I'm not sure that's been communicated to us, but we'll do some checking with everybody here. What does the R mean by the cases? Someone entered the question, what does the R mean by the case in some IDES cases? I'm not sure what you're referring to, but if you could screenshot that and send it to your field epi, we'll look into that for you. Can a local public health office maintain a supply of tests if they don't do testing in case they're needed by a long-term care facility? I think as long as we're talking about a small number of tests, I don't see that as an issue. You just need to order those through the state hygienic lab. There are some restrictions on the number of tests that each entity can order. I think you can order 6 at a time. Certainly that's something that you can do.
That restriction off.
Oh, Rebecca says that's no more.
No, but you just have to remember that they have to be refrigerated.
Okay. Should we follow the 7-3 rule regardless if a healthcare test positive or negative? So I'm thinking that means if someone's symptomatic and the PCR result is negative, would they still follow the 10-3? Yes. Some questions about the daycare guidance. Again, Department of Human Services issues that guidance, and certainly that's available on the website. And if you have questions, there's a point of contact listed there, I believe. There's a comment, we are not getting those alerts. I assume that means when we were trying to do those address corrections. Like I mentioned in the presentation, we're trying, IM is trying to build a workaround. So hopefully that will not happen in the future. We appreciate your patience with that. The other thing that you can do if you're concerned is they should be in your open case wizard, or you can always do an IDES query. So even, I know that that's not the answer you want. We're going to try and fix the IDES alerting issue, but again, there's other ways to get to those results, you would still have access to them. Questions about funerals and weddings. Again, I apologize. Those will be in the governor's future proclamations. We do also have a number, a legal consultation number, if there's questions about what is and is not appropriate. And so I can try and send that out with the follow-ups to this webinar. I think we've sent that before, but I'll send it again. Will email notification be sent with positive serology results like PCR? Yes, that's our plan going forward. We're going to turn that on Monday. I just didn't want, we've got quite a few serology results in the system, and I didn't want everybody to get like, 100 alerts about cases and not have the background. So yes, moving forward, starting Monday, you will get alerts for positive serology. A lot of questions about weddings and funerals. Some problems with the audio. I apologize. Hopefully that didn't happen for everybody. If you have questions about IDES installations, Jill Newland would be your point of contact, and you can get to her by calling our 800 number, 1-800-362-2736. Jill's our IDES coordinator. Can you explain the push for serology testing? Sure, good question. So really what the serology information is going to help us all understand is what % of our population may have already been infected with this virus. And so it's going to be important for us to kind of understand where we're at in the response effort as far as how many people have been potentially infected already. I think it's also helpful information for workforce. So I think that's what you're asking. All right, I've done the additional 10 minutes. We've still got many questions we aren't going to be able to get to. Most of these questions, I think, are repeats. I see a couple of questions about the recovered people who are having symptoms again. I think that's important information. And we'll get back to you with some guidance on that. I appreciate that feedback. So I guess just in closing, I want to reiterate to everyone how appreciative we are for all of your ongoing efforts. We know this has been a long road, and we know we've got a long way to go. And we certainly just appreciate your willingness to continue to work with us and be flexible and understand that things are changing really quickly, and we're doing our best to kind of make sure that we're communicating these changes to you. Sometimes that's effective, and sometimes we don't get there in time. So again, we apologize for that, and just appreciate your partnership. So we'll talk to you again next Wednesday. As always, if you have questions in the interim, reach out to your field EPIs, and we'll do everything we can to support you. Look for those additional resources I mentioned coming to you later today, as well as that new survey asking which investigations you want to do and which ones you want the state to do. So thanks so much, and take care, everyone.